Welcome to the second of 3 anatomical pupil lectures. Today we are going to discuss what will happen if there are defects in the central pupillary pathway and the parasympathetic portion of the efferent pathway. So we'll start with the central nervous system pathway. Lesions of the midbrain can affect the track between the pretectal and the Edinger-Westphal preganglionic cells, including the posterior commissure, where the fibers cross when they're traveling between the pretectal and Edinger-Westphal nuclei. A lesion in this tract results in a pupil that shows poor direct and consensual responses to light, but it responds normally to a near target. And this is called light near dissociation. The near pupillary response bypasses the central portion of the pupillary light response. Remember that accommodation, convergence, and meiosis, a pupillary reaction, work together to keep objects clear and single when adjusting focus at different distances. Accommodation brings the object into focus. Convergence moves the eyes so that the fovea is aligned with the near target, and this helps us to avoid double vision. And then meiosis increases the depth of focus. The pathway that controls the near pupillary response is different from that of the light reflex pathway. It does have an afferent, central, and efferent portion. The afferent pathway follows the visual pathway. But this one goes all the way back to the occipital cortex. Remember that the light pathway only went to the lateral geniculate nucleus. So rather than light, the signal that starts the near pupillary reflex is going to be either blur or double vision. From the striate cortex, a message is going to be sent from the occipital cortex to the frontal eye fields. This is part of the central nervous system portion of the near pupillary pathway. The frontal eye fields then connect directly to the midbrain, and specifically cranial nerve 3, the ocular motor nuclei, which contains both the Edinger-Westphal preganglionic cells and the fibers that go to the medial rectus. From cranial nerve 3, the signal goes to the medial rectus, which will cause convergence. From the Edinger-Westphal nucleus, the signal travels through the parasympathetic fibers to go to the sphincter, which will cause meiosis, and will go to the ciliary body muscle, which will cause accommodation. So this part is the efferent portion. This part is the central portion, and this is the afferent portion of the near pathway. Now, to draw out the near response, we're going to need to draw the rest of the brain. So we're going to, again, start with the anterior visual pathway, which we were drawing previously. And we've got our lateral geniculate nuclei. And we're going to draw the midbrain with the pretectal and the Edinger-Westphal nuclei. I do want to point out that I'm drawing the Edinger-Westphal preganglionic cells a ways away from the pretectal nuclei so that we can see the fibers as they cross. But the Edinger-Westphal nuclei is part of cranial nerve 3, which is on the dorsal side of the midbrain. So let's follow the fibers back from the right eye. We're going to have nasal fibers that go through the optic nerve. They go through the chiasm and back to the lateral geniculate nucleus, where they're going to synapse. And from here, the near pathway is going to go through the radiations back to the occipital lobe. We also have temporal fibers that are going to go through the optic nerve, through the chiasm, and through the optic tract to the ipsilateral lateral geniculate nucleus. Then those fibers, again, are going to go through the optic radiations and back to the occipital lobe. From the occipital lobe, these fibers are going to go all the way back forward to the frontal eye fields. And this occurs on both sides. From the frontal eye fields, this is going to go directly into the Edinger-Westphal preganglionic cells. From here, the near pupillary pathway is going to follow the same pathway as the light reflex. So it leaves the Edinger-Westphal nucleus in cranial nerve 3. It goes up and synapses in the ciliary ganglia, and then goes to the iris sphincter and the ciliary body muscle. And the same thing will happen on the other side. Get to the ciliary ganglia and then to the iris sphincter muscle. Now note that these fibers take a more anterior pathway in the midbrain. So a lesion in the posterior midbrain will cause a poor light response without affecting the near response. If you get damage to cranial nerve 3, for instance, you get a lesion here, then it's going to affect both the light and the near response because those two pathways travel together in cranial nerve 3. There are a few conditions that result in light near dissociation. And the most classical condition associated with light near dissociation is Argyll-Robertson pupil. Here, you're going to get bilateral light near dissociation. Without any light stimulus, the pupils are going to be very small. Sometimes they are less than 1 millimeter, even in dim illumination. Here we see an example of light near dissociation associated with neurosyphilis. You can see that the pupils are extremely small. You can see the transilluminator coming in and putting light into the eyes, and yet the pupil size does not change at all. Note that the pupils are very small. Now you're going to see the patient converge, and you'll see that despite how small those pupils are, they get even smaller very quickly with convergence. So this is light near dissociation. The pupils do not respond to light, but they respond very briskly to an accommodative or near target. This condition is most commonly due to neurosyphilis, but it can also be caused by diabetes, chronic alcoholism, or multiple sclerosis. Another cause of light near dissociation is dorsal midbrain syndrome. This occurs when something, most commonly a tumor, is pushing on the posterior midbrain. Remember, that's where the fibers are crossing between the pretectal and the Edinger-Westphal areas. Here we're also going to get bilateral light near dissociation, but the difference from Argyll-Robertson pupil is that these pupils are often mid-dilated. We don't get that pinpoint pupil that you'll see with Argyll-Robertson pupil. Most commonly, this condition is due to a pineal gland tumor because the pineal gland is directly behind the posterior midbrain. Let's look at an example of the pupil reactions with dorsal midbrain syndrome. Here you'll see the pupils are fairly normal size, but they don't react to light. Now when he converges, you can see that very quickly those pupils get smaller. And when he looks back in the distance, they dilate again. So again, this is an example of light near dissociation. Let's move on now and talk about efferent pupillary disorders. There's two types of efferent pupillary disorders. There's a lesion of the parasympathetic system and a lesion of the sympathetic system. Today, we're going to cover the lesions of a parasympathetic pathway. A lesion of the efferent pathway will have anisocoria. Specifically, a lesion of the parasympathetic efferent pathway will cause the ipsilateral eye to show a poor, direct, consensual, and near pupillary response. So this pupil is not going to react to any stimulus. There will be ipsilateral mydriasis, so you have a dilated pupil on the evolved side, and you will have anisocoria that's worse in bright light. Remember that an afferent defect will not cause anisocoria. An efferent defect will cause anisocoria. Normally, bright light causes both pupils to constrict. Since the innervation to the sphincter doesn't work when you have a parasympathetic lesion, the normal pupil constricts to light, but the abnormal one does not constrict. And this is what makes the anisocoria worse in bright light. In dim illumination, you may still have some anisocoria, but since it's mainly the dilator working, you'll have less anisocoria. There are a few causes of parasympathetic pupil abnormalities. One of those is a cranial nerve 3 palsy. Here, in addition to a pupillary disorder, we will typically get ophthalmoplegia. The superior rectus will be involved, the medial rectus may be involved, the inferior rectus, the inferior oblique, and the levator will be dysfunctional. Keep in mind that pupils are going to be spared in an ischemic lesion, such as diabetes, but pupils will be involved and abnormal if we're dealing with a mass lesion, and specifically, we want to worry about an aneurysm. Let's look at an example of a pupil sparing third nerve palsy. You can see that this patient does have significant ptosis, and when we raise the eyelid, the right eye is pointing outwards. Now we're going to test the pupil responses, and you can see that both pupils respond well to light. This is more indicative of an ischemic lesion to cranial nerve 3. Another cause of a parasympathetic pupil disorder is tonic pupil. Tonic pupil is caused by damage to the ciliary ganglia or the short ciliary nerves. So this is a post-ganglionic problem. Remember that by the time we get to the short ciliary nerves and ciliary ganglia, the rest of the extraocular muscle nerves have left cranial nerve 3. So we don't get any extraocular muscle involvement with a tonic pupil. You do still get anisocoria with the affected pupil larger, particularly in bright light. There will be a decreased response to light and a loss of accommodation. In addition, since this is specifically due to a lesion in the ciliary ganglia or short ciliary nerves, you can get segmental constriction. This will cause an irregularly shaped pupil. And we'll show an example of that here. This is an example of a patient with a right tonic pupil. You'll see that the right eye is not responsive to light, but you can see the irregularity of the pupil borders, which is characteristic of a tonic pupil. When you shine light in the left eye, you can see that the left pupil constricts, but the right does not have a consensual restriction. Another feature of tonic pupil is stromal streaming. And here you get contraction of the iris in areas that still have muscle strength. Those areas of the iris pull on the weaker areas. So you end up getting the iris pulling towards one particular area. In this case, the iris is going to pull towards the 5 o'clock position. Still, another characteristic of tonic pupil is that you can get sensory loss of the cornea. This may be present because the sensory fibers from the cornea pass through the short ciliary nerves and the ciliary ganglion. With tonic pupil, you'll get a slow, prolonged near pupillary response. And this is shown in this image. This is a different patient. This patient has a tonic pupil in the left eye. So you'll see that the right eye constricts well to light. The left eye does not constrict well, so you get more anisocoria in bright light. But when we ask her to look at a near target, you'll see that the pupil constricts very slowly to a near target. When she looks back at the distance, it dilates very slowly as well. One theory as to why the near pupillary response remains partially intact is that you get aberrant regeneration of the fibers. So remember that within these ciliary nerves, we have fibers going to the ciliary body, and we have fibers going to the iris sphincter. If we have damage to the iris sphincter, occasionally those ciliary body fibers will regenerate and grow towards the iris sphincter. Then, when the brain tells the ciliary body to contract, both the ciliary body and the iris sphincter contract. So you get that slow near constriction. Another thought is that the innervation to the ciliary muscle is greater than innervation to the pupil. Remember that there are 30 nerve fibers going to the ciliary body for every one nerve going to the sphincter. So some ciliary muscle fibers may remain intact. These remaining fibers secrete acetylcholine into the aqueous. The acetylcholine then travels to the iris, and this causes the supersensitive sphincter to constrict very slowly. That same concept of supersensitivity allows you to do certain pharmacologic tests to help differentiate this condition from other conditions. Cholinergic denervation supersensitivity means that the sphincter muscle is sensitive to even small amounts of neurotransmitter. So we can do pharmacologic testing using pilocarpine. Pilocarpine is used normally at 1% or higher concentration in the treatment of glaucoma. And this will normally constrict the pupil, opening up the trabecular meshwork. If we dilute the pilocarpine to an 1/8%, this will have little effect on a normal pupil, but it will cause significant miosis in a tonic pupil. The involved pupil will constrict more than the normal pupil. You can see the results of an 1/8% pilocarpine on this gentleman. Here he has a tonic pupil in the right eye. We put an 1/8% pilocarpine in both eyes. The left eye pupil really did not change significantly, but you can see that the right pupil responded to the 1/8% pilocarpine by constricting. There are a number of causes of tonic pupil. An autonomic dysfunction, such as diabetes, can cause a tonic pupil. Generally, this is going to be bilateral. An orbital mass affecting the ciliary ganglion can cause a tonic pupil. And orbital trauma or surgery is a very common cause of tonic pupil, particularly in those who have had retinal detachment surgery. Tonic pupil can be idiopathic, and in this case, it's termed atonic pupil. This is a degenerative process resulting in parasympathetic denervation, but it is idiopathic, meaning we don't know the cause. It occurs most frequently in female patients between the age of 20 to 40 years. The same process that is happening in the ciliary ganglia occurs in the spinal cord. So some patients have diminished tendon reflexes as well. A pharmacologically dilated pupil results in a fixed, dilated pupil of recent onset. This may be caused by medications that have anticholinergic effects. One example of this is scopolamine. This is used to prevent motion sickness and will cause a dilated, non-reactive pupil. A pharmacologically dilated pupil is more common with certain professions who handle chemicals, such as nurses, pharmacists, or farmers. Testing for a pharmacologic pupil is done with full strength 1% pilocarpine. Generally, you will first test them with an 1/8% to rule out tonic pupil. If this doesn't constrict the pupil, then use 1% pilocarpine. A pharmacologically dilated pupil will not respond to either an 1/8 or 1% pilocarpine. Lastly, I do want to mention damage to the iris. This can cause a non-reactive pupil or an irregularly shaped pupil. It can be due to trauma, like a tear of the iris. It can be due to inflammation, like a posterior synechiae, or it can be due to ischemia, which occurs with angle closure glaucoma. So that concludes our information about central and parasympathetic efferent pupillary disorders. The final session of pupils will cover sympathetic efferent disorders.